Welcome to this discussion with Jan Filochowski, who has made a presentation at the Westminster Open Lens as part of the Reboot at the start of the new parliamentary session. Jan, you indicated that you thought that the extra funding was a significant change in attitude by the government. I remember a moment in the late 80s when Mrs. Thatcher increased the money quite significantly. Most people will remember when Tony Blair made his matching the European averages promise, much to the shock of Gordon Brown. Do you think that's a long-term change, or is it really dependent on whether or not the 20 billion that goes in produces results, or we'll be back to a review and what's next after the NHS? Is this a last chance saloon for this NHS model?
I don't think so, but nor do I think it's necessarily the solution, and this jury is out on that at the moment. I think the worry is, I mean, first of all, a very big commitment, so that is good. The worry is that I don't think the government is clear what it wants from it, and it is preoccupied with other things. And I think it needs to really commit to it, it needs to get a mojo. You mentioned the Tories in the 80s, and I think when they started to change things, they only became effective. And I believe that in the later Thatcher years into the early 90s, they were very effective in both making an investment and having an understanding of what they wanted from it. And I do remember, I was a civil servant in the Department of Health when Norman Fowler was Secretary of State, and they'd asked for a report on manpower from a guy from Sainsbury's called Roy Griffiths. And Roy Griffiths said, I'm not going to write about manpower, I'll write about how you manage the NHS. And they were so desperate, they said, okay, go on. Anyway, he wrote this report which was completely different from what they expected. Not a posh thing, it was 14 pages of hand-typed material. And I know, because a friend of mine who was in the room, it was handed to Norman Fowler, and he read it and he said, this is the answer. Why has no one told me this before? And, you know, he ran with it.
General management.
And we've got general management. And again, second time round, when there was a financial crisis around about the Lawson time, and the government had quite a lot of money to spare, but they said, we've got to run it differently. And they created the provider-purchaser split, which again, at that time, made a fundamental difference in the way the NHS was run and enabled change, I think, to roll through. And again, the third thing is, when the Labour government put the money in, the matching was very important, but I think the real key was when Alan Milburn realised, and I think Tony Blair realised it at quite a high level, that you had to change the processes in management, and we got redesign, re-engineering. And, you know, I was one of the people at the forefront of that. We fundamentally altered processes, but we needed the money to enable us to do that. And what I think this government hasn't yet got is to say, this is what we're going to spend the money on, and so we will get this result. And I hope they'll find it, because when they find it, they will believe that they're making the investment properly.
We had a presentation yesterday that looked at 2015, the forgotten election. Obviously, people remember the 2017 one, the Brexit one, but the 2015 election, and around that, some quite significant shifts in Conservative approach, because there is now a bias against what I would call whole system reform. If you look at local government, George Osborne is allowing mayors, elected mayors, to evolve in different places, not imposing a solution on the whole country. Now in health, they've taken the first step in that, devolving the health budget, 6 billion, to Manchester. And in a way, leaving it to see whether or not they can do or find a route to integration and then roll out what works. What do you think of that approach rather than the kind of sweeping all system approach that Lansley and others have taken before?
I think there's much to be said for it, but in my view, you have to devolve more. You have to devolve, rather as has been done, say, with the devolved administrations of Scotland, Wales and Northern Ireland. You devolve it, and in the case of Scotland at least, you say, it's up to you if you want to spend more on it. And the Scottish Government's decided to do so. So I think you have to be prepared to, once you go down this road, you can't just say, oh, by the way, you're responsible, but we'll decide how much money you have, because I can't be responsible unless I know how much money I need. And I have to be able to say to you, as the government, you've devolved this to me, but that's not enough to do what you've asked me to do. And so I think one of the ways forward may well be that you have national funding, but with devolved administrations and some relatively small local top-up out of local council tax or possibly even a dedicated health tax or health and social care tax.
One thing that you said that was interesting is that the demand for healthcare is not ballooning, that the way that it is growing is actually predictable and is known to the policy makers. That is quite a different message from what most people receive in the media, which is that demand is unpredictable and therefore nobody's really to blame. It's like when a hurricane hits. But you're saying actually, given the scale of the NHS, you can see the demand that's coming down the line and it is predictable, and with some small variations you can work out your supply. Is that strongly your view?
Yes, it is. I mean, if you look at the last, I can't now remember because I haven't whether it was last year or the year before, the waits in A&E shot up. And also remember that there is a sleight of hand in the way they're presented. The government set itself, in 2010, the Labour government reduced the 98% target seen within 4 hours to a 95% target. So they reduced 2% waiting to 5% waiting, i.e. a 250% increase in the percentage in the numbers of people waiting. We got to 2015 and that was only just being met. And now we have less than 90% of people being seen in 4 hours, i.e. the number of patients waiting since 2015 has more than doubled again. So if I'm waiting, I'm not bothered that I'm one of the 10%, I'm bothered that I'm one of the ones who's waiting. And so what's happening is that keeps rising very fast. Now, if the number waiting has doubled and quadrupled, the number of people coming into A&E has gone up by 10, 15% over the same. Why has the number of people waiting quadrupled? There is no association. And I also checked, I think it was not last year, but the year before and the year before that, when waits went up, actually the number of people going through A&E in winter went down slightly. So there were fewer people and waits doubled. And this is also true in terms of elective care. The numbers of people wanting operations has gone up slightly, and the number of wait is going up by very large percentages. And the explanation, a lot of it, is with another statistic: the number of people waiting to be discharged from hospital who are no longer acutely ill but can't get out, and that number is ballooned, and that you're damming up the whole system.
Now you gave an example, you said from your own experience, that dysfunctional element was costing 1% to 2% of resources in a trust that you've been working at, and that your guess is that as things got worse, that could be affecting 3% to 4%. Those are huge sums of money spread across the system.
Absolutely.
It also means that the solution ought to be within the system. the management of the system, the clinical practice, risk aversion? What are the factors that are adding to dysfunction?
Well, yes in part and no in part. The problem is the impoverishment, the lack of resource in social care. You have to put that right. You have to have enough social care places, enough community support in the NHS so that you get a flow of patients. When patients are ready for discharge, they are discharged. So that means you have to make an investment first. You don't save any money to begin with, and that is the error. Oh, we just move the money around. You cannot do that. You've got to make an investment first, and then you will free up some money. But people have been unwilling to do. Many organisations taking over failing organisations have to put in an investment first. I expect even the guy who's just taken over House of Fraser is saying, you know, the ones I'm going to save, I've got to put some money into, and then they'll make money for me. It's the same. You can't say, oh, we'll take money out of hospitals that are already on their knees and put it into social care, because hospitals won't function at all if you do that.
Do you think there's a possibility then in the integrated, or supposed to be integrated system in Manchester, that instead of the sort of adverse incentives where, you know, hospitals are keen to get people out as fast as possible, local authorities are keen to keep them on somebody else's budget for as long as possible, that if you have a single budget, that therefore the incentives will be in the right direction to try and work out a care pathway that takes the pressure off?
Yes, I do think the incentives are there, though you have to have enough money at the end of the line. If you don't have enough money at the end, what can the people at the end of the line do other than push back? I mean, if you're down the line, you push that way, but if you know when to push that way, you push back, and then you get a blockage. So, for example, in Sweden, I quite like the idea what they do, but they do fund the NHS more generously. There is a legal requirement to discharge patients who are no longer ill within 48 hours. So if you don't accept them, you're breaking the law. Now, again, it's quite helpful that the county councils also run the hospitals. And the Swedish system has much wrong with it, but it knocks spots off us.
Now, the other point you made about change was about early diagnosis and the commitment to that. Now, there has been an explosion in attempts at behaviour change. We heard all about the Measure the Health of Your Heart app in the past few weeks. But the early diagnosis and testing, there seems to be a lot more of that being rolled out, much more targeted earlier. Is that something that you think is growing fast enough, or are we still far behind what they do in other countries?
I think a lot of the screening we're doing is very good indeed, and I'm not an expert in this field, but I think there's every reason to think we're up with others, and in a purely privatised system like the US, we'd be in advance of that, because they wouldn't do the amount of universal screening that we do. I think where we tend to fall down is in terms of the more random detection of stuff that's already beginning to happen. And because GPs are so hard-pressed and are not specialists, they may on occasions not get stuff. And I mean, it may be to do with the British character, who's to say, in those circumstances, people don't go and present themselves when they have what seems like a minor misdemeanour, or oh, I've got a little lump here, oh, it's probably nothing. Whereas if you have a culture of, I've got to go and have that seen to, then you will get the early detection. But when primary care is overwhelmed, the incentives are to push you away from that, because we haven't time to see you, we haven't time to look into that.
Okay.
So it's, again, creating the space, and once you do that, you start to do it more effectively and stop the ballooning.
Okay, thank you very much.